Welcome to the Sudanese Orthopedic Surgeons Association, SOSA presents Extracapsular Fractures of the Proximal Femur webinar.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين. نتكلم الموضوع it's a simple way we are looking at it is just as the title of the seminar is extracapsular and intracapsular. So the intracapsular, we know that the blood supply is a problem, the healing is a problem, so the treatment is replacement, where extracapsular, the treatment is fixation. The part is mentioned in the previous sections. Practically, classification has no major roles. Classification per se is important, first for communication, second if it guides the treatment, and third if it tells about prognosis. So the classification, Evans and AO, generally they don't tell the treatment exactly. So and all the classification, Evans classification was very old. The importance of posteromedial calcar is not practically now used these days here in the UK and in Europe and the rest of the world. The lateral wall is actually the most important. And the treatment goals, there is guidelines here we work with. In the UK is nice guidelines, but it's universal. The principles are the same. So those patients generally, they're elderly, a part of the high velocity trauma, road traffic accidents, and the majority of neck of femur fracture and in elderly patients, frail, multiple comorbidities, and multiple health problems. So the goal of the treatment is, first one is immediate weight bearing. So you need to give them an operation that they will start weight bearing immediately. Now here in the UK for intracapsular neck of femur fracture, there is moving away from screws, cannulated screws, because till now most cannulated screw fixation, you cannot allow the patient immediate weight bearing, and we are moving more towards doing DHS and derotation screws. So the first goal of treatment, once you know that this is an extracapsular neck of femur fracture, is to aim for a fixation option that gives you immediate weight bearing. And once you achieve your first goal, the second goal is to give the maximum chance to allow for fracture union, and then reduce your complication risk, infection, non-union, reoperation, cutout, and then allow rehabilitation of the patients. So the fixation options depends on whether the fracture is stable or unstable. The Evans classification is not useful, and there is no, the AO classification is not that useful. What will decide, what practically and pragmatically decide your fixation method is mainly the lateral wall. If the lateral wall is intact, then you can use a DHS. A DHS is very good device, although it was been in use for more than 50 years, but still very good device, very cheap, universally, and it achieves very good results. Unstable fracture, one of the options we'll come to it is either intramedullary nail, which biomechanically stronger, is on-axis fixation. It have a shorter lever arm. It is weight-sharing device, and it will give you a better option. One of the options I want to talk to you about, and I'm not sure whether you have experience with it or it's not known to you widely, but I think it is very good option to be known in Sudan. It's very low cost, and it have excellent result, and that is using dynamic hip screws DHS plus TSP, which stands for trochanteric stabilization plate, and I'll talk about it when we discuss a case. The intramedullary nailing, we know it's more biomechanical, it's stronger, it's weight sharing, it has its on axis fixation, and it has shorter lever arm, and the nails options are short nails versus long nails. The short nails in part of the world, especially North America, are done for stable fracture instead of DHS. In USA, almost they don't do DHSs. Most of the stable fracture will be fixed by short nail, and the long nail has their own indication. So one of the landmark papers, and it's very, I find it very, very simple, very comprehensive about intertrochanteric fracture, is a paper published in American Journal of Orthopedic Surgery in 2009 by Jaweesh, and it talks about 10 tips to improve the result of your intertrochanteric fractures. And the first one, and the most important one, Hashimi Mahbub mentioned it, is the integrity of the lateral wall. So no lateral wall, no DHS. And that's current, and we still use it. In reverse oblique, the lateral wall is broken, so you cannot use DHS classically, but you can use DHS and TSP, and it will work perfectly. And I'll come to that in a few minutes. And then he mentioned other emphasis in that paper is about the tip apex distance, which classically in the old generation, the DHS, the teaching was to put the screw inferiorly and posteriorly, because that's the most strong bone in the femoral neck. But since the work of Jaweesh and others, the new concept of tip apex distance came, and that you need to keep your lag screw for both the nail and the DHS central in the canal, in both planes, in the coronal plane and in the sagittal plane, with an optimal tip apex distance of 25 millimeter combined. So, and roughly that's 1 centimeter from subcondylar bone, both in AB and in lateral plane. And then the other important principles in that paper that identify the unstable button and nail them. So if you realize that this fracture is unstable, then you have to nail it. Deciding of stability is the main, is the most important factor to decide which fixation option you will do. There is the X-ray will give you a guide. If you do further imaging, CT scan will give you guide, but the most important one is intraoperative decision. So when you take the patient to theater, you put them in traction table, you reduce it out to length, and then you decide. If the fracture is stable the easy option, the simple option, the most cost-effective option is dynamic hip screw. It can be done quick operation. In major trauma centers here in the UK, they think most displaced and comminuted fracture is better done by open reduction. And the open reduction mainly is a DHS more than the nail. There is no DHS. You can do it percutaneous. You have to open the fracture and reduce it anatomically or near anatomical, and then you apply DHS. So the DHS is for stable fracture, but the most important factor is the lateral wall. The posterior medial wall and lesser troch is irrelevant. Nowadays, we don't pay any attention to it, whether it is broken or not, or whether a large posterior medial fragment is there, unless it's extending to the subtrochanteric region, as we mentioned in the first two talks. Once you realize intraoperatively that your lateral wall is intact, then the most important factor for your DHS to work is the quality of your reduction. And so you reduce the fracture normally when you put the fracture, the patient on fracture table, and after you position the leg and you fix it, you adjust your fluoroscopy. You leave the leg in the foot in external rotation. You apply your traction till you feel that your fracture is reduced out to length, and then you adjust your internal rotation of the foot to compensate for the hip anteversion. Not all the fracture require immediate internal rotation. Subfracture we reduce in neutral position. And once your fracture is, also there is the rotation of the anterior neck. If it is the neck is anteriorly not mal-reduced, that's a predictive factor for failure of your DHS. Once your lateral wall is intact, you did good reduction, you avoid varus, the neck is not in varus, then the next step is to put your guide wire center in both planes in the AB and lateral with optimal tip apex distance of combined 25 millimeters, 1 centimeter in each plane. And the DHS, as we all know, it works by the controlled collapse. The fracture is metaphyseal fracture with rich blood supply, with a weight bearing that will encourage the controlled collapse of the fracture of the lag screw inside the barrel, and that causes compression at the fracture side and encourage healing. So this is just a simple case, intertrochanteric fracture. We can see both in the AB and lateral view, and clearly it's a left side fracture. Intrafluoroscopy, it reduced, and as we can see clearly here, the neck shaft angle is low. The fracture is reduced anatomically, but it looks is low neck shaft angle. We have options of low angle DHS available. This was 130, not the classical 135. Left hip fracture, you have to use a derotation wire. Classically, years ago, they used to use a derotation screw for basal cervical or for left hip, but a wire is enough. Because when you put your lag screw, the rotation, the torque of putting it is a deforming force, and it's displacing the fracture. So unless you have a guide wire for a left hip intertrochanteric fracture for a DHS, you have a high risk of displacing the fracture. One of the most important tips, I can mention it here, you do not appreciate the displacement in the AB plane. you have to change your fluoroscopy to lateral view as you advance your lag screw. And clearly, any rotation will appreciate it in the lateral view. And it's very common with those fractures, despite you have a derotation wire. You'll see the neck in the last, when you put your last turns and the fracture is seated, you have optimal tip apex distance. You notice that there is mild rotation of the neck, and you can reverse it by half turn to make it reduced anatomically. So we did that, and here you see the fracture is the lag screw is in the center in both planes. The other fixation method I want to introduce you and encourage you that to try to find if it's, I'm not sure if it's available for you in the local market, is trochanteric stabilization blade. We know it's also mentioned in the talk of Mu'taz and Mahbub that the DHS failed by lateralization of the proximal fragment and medialization of the shaft, and that will lead to cutoff of the DHS. And trochanteric stabilization plate works by exactly stopping that. It buttresses the proximal fragment, it prevents it from lateralization, and then the DHS will never fail. Unfortunately, here in the UK and in the rest of Europe and USA, those population of neck of femur fracture, they do not get followed up. So most the patient will get the fixation and then they'll be discharged. There is no clinical follow-up. So there isn't a lot of literature talking about trochanteric stabilization blade, not large studies or big studies, but from practical experience from the centers, they're using it. For instance, here in Oxford, we have been using it for more than nearly 20 years, and they do not fail. So it has very sound biomechanical principle, preventing lateralization of the proximal fragment, medialization of the shaft, and it's very easy to apply. People who they are not familiar with it, I think it's need a lot of stripping of the muscles, a lot of bigger exposure. It's not. It's exactly the same DHS lateral incision. You just increase it by about 2 centimeters proximally. And it's very cheap as well. The DHS it's well known that cost-wise, it's one of the cheap devices, and trochanteric stabilization blade is also cheap. So this is how it looks. The one we use here is from Sensis, but I'm sure there'll be a lot of it available local to you in the market or in the Middle East or in the nearby countries. It has four screws, as you can see, and the way you do it is, yes. For instance, this is the DHS we recently did, and here you can see from the X-rays. Initially, you think that this fracture is stable. The lateral wall looks intact. So when we reduce it, if you look at the X-ray of the left-hand side of the screen, there is a small fracture extending to the posterior lateral wall. So when you put your lag screw, there is a risk this wall will be very thin, and then the DHS will fail. And here is TSB applied trochanteric stabilization blade. So it's exactly the same incision. It's the same reduction, and then you put your your guide wire and a do rotation wire, same as we explained in the previous case. And then once you put your lag screw, you put your side blade and you start you put the second screw from the top in the DHS side plate. So you put the second screw fully, then you slide the trochanteric stabilization plate, and it will sit on the side plate of the DHS. And this is exactly how it sits. It sits not on the tip of the the greater trochanter. It sits just about less than a centimeter from the tip. And then you'll notice that the three screws will match the three holes of the DHS. And then you put the rest of, you put your first screw will be through both your DHS plate and trochanteric plates, and then the two most distal screws. You don't need to strip any muscles, just only the skin incision will be 2 centimeters longer proximally. And this DHS, if it will fail, as we said, by migration of the proximal fragment and mineralization of the shaft, and this plate will prevent that. It's very easy, very cheap, very easy to apply, and it should be cost effective. The cephalomedullary nails, there is a lot of centers use short nails, as I mentioned earlier. A lot of it, for instance, in USA is financial gains because it's more expensive. And the cost of a short nail is almost the same cost of a long cephalomedullary nail. The older generation of the short nails also were not well designed, and they cause a lot of peri-implant fractures. Following them, a lot of centers abandoned that. That was in the last 10, 15 years. But the second generation or the current generation of the nails are biomechanically sound. They change the position of the distal lag screw. It's all done through the jig, as most of you have seen. You can do it in half an hour, but the cost of it is very high. So in our condition back home, it's better to avoid it, in my view, because it will put a lot of cost on the patient and family. For the long nails, the principles are the same. So quality of reduction is the most important. And the second most important is the entry point of your long nail. I'll talk in later. There was a myth or very wrong information. It's widely known that people will say that the nail will do the reduction for you. This is one of the biggest mistakes, that unless your fracture is well reduced, the nail will not do the reduction for you. So this is that fracture. Has very good reduction. And then you can see the long nail, and it gives a secondary prevention, because this population are elderly, are frail, they are prone to have more falls. So when you do a long nail for proximal femoral fracture, then you prevent the second fall to have further shaft fracture. The recent evidence, this is one of the most recent and large randomized trials published only 3 years ago in the JAMA, Journal of American Medical Association, and showed no difference after 1 year between using a DHS or intramedullary nail. So the current evidence that the DHS is not superior to the nail, or the nail is not superior to the DHS. What matters is that you decide intraoperatively which fracture is unstable. You achieve a very good reduction. The concept that the nail when the fracture looks unstable, not reduced, the nail will do the reduction. This is completely wrong, and it will give a very bad result. So first myth in the tips and tricks is that the nail will do the reduction for you. No, unless you do very good high quality reduction, your fixation, whether it's a DHS and trochanteric stabilization plate, or a nail short or long, your fracture will fail. Full stop. There is no two ways about that. And take your time. The most important, the most crucial factor is the reduction. So take your time, open the fracture if it needs opening, and reduce it anatomically, restore the tube, neutralize the deforming forces, restore your mechanical axis, length and rotation, and then do your fixation of your choice and what's available to you. The other important factor for nails, whether short or long, is the correct entry point. If you take one talk from this about nail, is the correct entry point, and it is currently there is new term introduced, widely used here now. It's trichoformis. So your entry is not in the tip of the greater trochanter. It's the most medial part of the tip of the greater trochanter. Part of it has to be in the piriformis fossa. Because if you go the more lateral, you put your entry point, the fracture will fall into varus, and then as it's mentioned, the biomechanics and principles, once the patient is the forces of the weight bearing goes, the fracture will fail, and eventually your nail will fail. Another tip I use a lot, use the finger reduction tool. When your guide wire is not positioned correctly, either too anterior, too medial, or too anterior, too posterior, take it out. Use the reduction finger reduction tool. In most of nails is available. Once you put your entry point correct, entry point, you reamed correctly. The first reamer is enough to introduce this device and then use it. So this is from the paper of Jaweesh about the 10 tips. So clearly the entry point is almost in the piriformis fossa. We know that the old generation, first generation, like Kitcher nail, the end was piriformis fossa entry. Then the concept moved away from it because it has high incidence of avascular necrosis. But the current emphasis now and the best result is when your entry point is the most medial of the tip of your trochanter, and part of it is piriformis fossa, and we use it currently in trauma world as trichoformis. So in trochanter and in piriformis. To avoid. This is another example of subtrochanteric fracture. This is a patient I just did only a few days ago. She's 91. As you can see from the quality of the bone, is paper thin. It is very comminuted. If you think you can reduce this closed, then you are wasting your time. You are adding 1 hour or more to your operation. She had a CT scan which showed that the fracture was very comminuted, and at least there was 4 parts of it. There is no lateral wall, and I went straight away for open reduction. And despite the fracture is very comminuted, so we could not get anatomic reduction, but alignment, rotation, restored. The tube is restored. Do not hesitate to use cables or K-wires so the tube remains maintained, the fracture fragment remains close to each other. Otherwise, you'll have a high risk of non-union. And I'll finish with that. Any questions?